Thank you again for having me. On the topic of modern management of myopia, I'll be discussing OCT in myopia and glaucoma and the issues that come up when we combine the two. I have no financial disclosures. During school and residency, I mostly used the Zeiss OCT, and now in my current position, we use the Heidelberg, so I'll be discussing a little bit about both. Myopia is associated with an increased risk of glaucoma, and studies have found that this risk is independent of other risk factors for glaucoma, such as IOP. This meta-analysis found that on average, the studies show that the risk of glaucoma is doubled in individuals with myopia versus individuals without myopia. Most of these studies are population-based surveys and observational studies. So I think it's important to note that not all studies have found a significant association between myopia and glaucoma. Specifically, the OATS study did not find a significant association. So that's important to mention because that's one of our landmark glaucoma studies that we rely on. The question of why might myopia increase the risk of glaucoma is a difficult one to answer because we don't have a definitive explanation for why we get glaucoma in the first place. A lot of the theories are mechanical based, higher susceptibility due to change in connective tissue structure in our highly myopic eyes. Regardless of the fact that we don't have a good explanation, it has become an important part of our clinical management of myopic patients. I just Googled myopia control brochures, and most of them mention the associated risk of glaucoma. So you have a highly myopic patient and you want to evaluate them for glaucoma. A lot of times my first step is the OCT, and this can be very challenging in our highly myopic eyes. Some of the issues that come up are disc margin delineation, segmentation issues, structural changes around the nerve, temporal shift of structures, and a lot of times these patients are outside of the normative database. Things that can affect the disc margin delineation are peripapillary atrophy, posterior staphyloma, myopic crescents, and tilted discs. You can see in this example that the fundus photo has a really nice round optic nerve and a myopic crescent next to it. On the OCT, it's including that myopic crescent in the optic nerve measurement. And this can be tough to pick up in more subtle cases because we're not always looking at the fundus photo and comparing to our OCT delineation. So it can be easy to miss. Segmentation issues come up a lot as well. So in this example, you can see that the tomogram is all over the place in the left eye, and this is just not a good scan. We wouldn't even bother to assess this data. We would just have to repeat and hope for a better result. The Heidelberg does have an option to manually refine the automated segmentation. So this was actually a patient of mine, and you can see that it's assessing the ILM. And in the top picture, we have the original scan where the ILM dips down all the way to the RPE. And then on the bottom image, you can see that round red cursor that I use to just bump up that line to where I think the ILM is. And I found this very useful because a lot of times with my patient flow, I'm looking at the dilated fundus exam, deciding that they might be a glaucoma suspect, and doing the OCT on their way out, and then calling them with results and follow-up plan. So when they're no longer in the chair, I can't repeat the scan. This has come in handy a lot. There are cases where no amount of segmentation adjustment can help. Myopia is associated with a lot of retinal changes that can be around the nerve. So in this example, you have kind of extreme tractional changes, a hole in the inner retina, schisis and cystic spaces. So really no amount of segmentation is going to get you a good scan here. And again, to give you a specific example, This is a patient of mine that came in for a glaucoma follow-up while I was making these slides, so I decided to pop her in here as well. Overall, the segmentation is okay, but you can see all these little cystic spaces throughout the scan are really going to mess with our results. And on the T-SNP curve, you can see that in some places it goes all the way down to 0. And we know that's not really physically possible because we have the floor effect where there's kind of a minimal residual thickness that's left from the glial tissue and the non-neural vascular tissue. So when we dip down all the way to 0, we know that it's not a good scan. We have something else going on. In a lot of myopic patients, you have a temporal shift of the major blood vessels and the RNFL bundles. So this paper showed a great example. Here you can see the black arrows are pointing out where the normative patient would have their RNFL bundles. And these hollow arrows are showing where this patient has their RNFL bundles, and they're kind of dislocated towards the temporal side. In the T-SNP curve, the black arrows show where the normative RNFL peak would be. And you can see that the red arrow, which is the peak of this patient, is shifted over to the temporal side. So then it's up to you to decide whether this thinning that's flagged here and here is true glaucomatous thinning, or if it's kind of a physiological variation of normal due to this temporal shift of structures. So how do we decide that? The ganglion cell complex is a great tool. And I would definitely prefer to see this left-hand picture where you see a robust ganglion cell complex, everything in the green. That would definitely make me feel better. I would not want to see this right-hand picture where there's diffuse thinning and ganglion cell loss. That would point to more of a pathological process rather than a variation of normal. Studies have looked at specifically comparing the RNFL scan and the ganglion cell scan in highly myopic patients as it relates to glaucoma. In this first study, they looked at only high myopia patients and diagnosed glaucoma based on IOP, visual field, and the appearance of the nerve. They then took the OCT and looked at how good the RNFL scan and the ganglion cell scan was at detecting glaucoma. They found that the GCC thickness scan was comparable to the RNFL thickness scan in detecting glaucoma in high myopia patients. The second study separated subjects into a high myopia group and an emetropia group. And they found that the GCC showed a good ability to detect glaucoma in both groups, whereas the ability of the RNFL measurement was inferior in the myopia group versus the emetropia group. So all of this is saying that your ganglion cell complex can be a great adjunct or alternative to the RNFL scan in detecting glaucoma. But again, our retinal changes associated with myopia can really mess with our scans. In the left picture, you have an extreme example of tractional schisis. And in the right, you have an example of a myopic CNVM. So we have to take our scans kind of with a grain of salt in our highly myopic patients and keep an eye out for other structural changes. Finally, these patients might be outside of the normative database. This is from the OCT user manual. And you can see here that the range of refractive errors for the normative database goes from -12 to +8. So I have two quick cases to show as examples of these kinds of issues. The first one was a 65-year-old white female who presented for an annual diabetic exam. Her last eye exam was over 3 years ago, and she was lost to follow-up since. Her history was significant for high myopia. There was no diabetic retinopathy found at the last exam, and she was a glaucoma suspect based on her optic nerve appearance. And she had no family history of glaucoma. Her refractive error was about -14 in the right, -15 in the left, so outside of our normative database. Best corrected vision was about 20/30. She had some early age-related cataracts. Her max IOP was that visit, and it was 16 in the right, 15 in the left. And her phakimetry was slightly below average at 523 and 526. So I dilate and I look at the nerve. I have red-free images from the OCT. They're a little unclear, so I did draw what I was thinking clinically. In the right eye, definitely a large cup with vertical elongation. And same in the left. Clinically, my main concern was superior temporal in the left, circled in red, where the cup really seemed to go all the way to the rim, and there was pretty much no rim left there. So we do our OCT and we check for reliability. Here you see the tomogram of the right eye, and we have these artifacts where the retina is all the way out of the scan. And unfortunately, this is right in our superior temporal area, which is where we see a lot of our glaucoma damage. So not a reliable scan. We'll just put a big X through that and try to get a better scan in the future. Left eye looked a little better. Maybe some ILM poor delineation over there and over there, but overall a pretty good scan. And we see superior and inferior RNFL thinning. Luckily, I was able to pull up the scan from 3 years ago and compare it to today. The numbers are a little hard to see, but you can see just based on the colors that we have some progression with more thinning today. And you can see on the T-SNP curve as well, superior temporal and inferior temporal 3 years ago, we were above that average normative line. And today we're dipping below both superior temporal and inferior temporal. So I had her back for a visual field. It was her first time taking a field. So in the right eye, not the most reliable. We have some fixation losses, and the gray scale was reminding me a little too much of that cloverleaf pattern, indicating an unreliable field. But we do have some nasal defects that we'll keep an eye on. In the left eye, more reliable, and we have this big inferior arcuate defect that is very concerning because it involves one of our central points there. So for this patient, my main area of clinical concern was superior temporal in the left eye. We had structural thinning on OCT and signs of progression when we compared to the scan 3 years ago, and this big field defect. So we have structure, function, progression. I decided to treat this patient. My second case starts off pretty much identically. A 70-year-old African-American female presenting for an annual diabetic exam. Last eye exam over 3 years ago and lost to follow-up since. Just like the first patient, high myopia, no diabetic retinopathy, and a glaucoma suspect based on her nerve appearance. Unlike the first case, this patient had a positive family history. Her father and her sister were both treated for glaucoma. She had a refractive error of -6 in the right, -7 in the left. Best corrected vision 20/40 with some age-related cataracts. Tmax of 14 in each eye with a thin pachymetry of 478 and 476. So we look at the optic nerve. Right eye, I was concerned about the inferior rim there, that little dip that looked like a notch. Left, a little bit better of an appearance with a round cup and a pretty robust rim superiorly and inferiorly. OCT, a pretty good scan. Our tomograms look good. In this case, I would argue that instead of a temporal shift of structures, it looks like there's a nasal shift of structures. So you can see the major blood vessels kind of course nasally before going temporally. And on the T-SNP curve, this patient has peaks that are a little bit more nasal than the normative database. So this could explain our borderline findings here in the right eye. In the left eye, same thing, our superior peak is shifted a little nasal. It's actually the inferior one here in the left that I'm a little more concerned about. In comparison to our first patient had more of the classic temporal shift appearance. You can see the blood vessels coursing temporally here, and this is our current patient with her nasal shift. Next up, we did our visual field. Right eye, a little bit of an enlarged blind spot, but happy to report no glaucomatous defects. In our left eye, again, an enlarged blind spot, and these two inferior points, not a significant cluster, something we'll keep an eye on, and it didn't really correspond with our inferior area of concern on the OCT. So to summarize this quick case, our main area of clinical concern was inferior temporal in the right eye. We had some borderline findings on the OCT that I kind of convinced myself were due to this nasal shift of structures, and that's something we'll watch over time. We'll watch for progression. If it stays stable, that would be great. And her visual field looked great, no glaucomatous defects. So we don't have a good structure function correlation, and we haven't established any progression. So in this case, I decided to observe. We'll repeat some testing in the future and keep an eye on her. I have one last case, and in this final case, we actually have a high IOP to talk about. This was a 72-year-old male presenting for a follow-up exam. He was followed for ocular hypertension. His max IOP was 26 in each eye, with a thin pachymetry of 496 and 506. His refractive error was a little lower than our first two cases, a minus 575 in the right eye and 525 in the left, with a best corrected vision of about 20/30, some early age-related cataracts in each eye. And his IOP this visit was 24 in each eye. So looking at the optic nerve, a little surprising for a moderate myope. He has very small optic nerves. And again, I try to draw out the cup. It's a little tough to tell with all those blood vessels coming out of such a small space, but that's where I thought they might be. And because of his high eye pressure, we did an OCT. I don't think just based on the clinical appearance, I would have done it. But when we do the OCT, we're a little surprised to see these areas of thinning flagged. So when you take a closer look, his disc area is very small. And in a small disc, you expect kind of a minimal cup, but his CD ratio is being called a 0.37 and a 0.30. So that's probably a little bigger than we would want in such a small disc area. And just to compare to normal, the normal disc area is about a 2.1 to 2.35. So his is very small. And whenever we do the RNFL on the Zeiss, we always do the GCC as well. And just like we look for structure and function to match up between our OCT and visual field, we look for our structure and structure to match up between the RNFL and the GCC. So in the RNFL, we had some areas of superior thinning in both eyes. And here we see on the GCC, we have superior thinning in both eyes as well, respecting that horizontal meridian. So definitely suspicious for a glaucomatous process. In this case, we chose to do a 24-2C visual field because that thinning in the ganglion cell complex made us more concerned of a central defect. And we know that in our 24-2C, we have these extra central points that look for central defects. In this patient, his right eye visual field looks pretty good. No glaucomatous defects, a few spots here and there, but nothing significant. And same in the left eye, a few spots here and there, nothing significant. So for glaucoma, we always track change over time. And just to give the left eye as an example, we can look at our glaucoma progression analysis for both the RNFL and the ganglion cell complex. So I'd argue that especially in the ganglion cell complex, we have some slow change over time. You can see these linear regressions show the change over time, and we have about a 1.5 micron decrease per year in both the superior and inferior thickness. So definitely concerning when you see change over time. And in this case, it was really both the RNFL and the ganglion cell complex that gave us the complete picture. So in summary, population-based studies have shown that myopia is associated with an increased risk of glaucoma. Many highly myopic patients are glaucoma suspects based on their nerve appearance. They have large nerves that are tilted and cups that are vertically elongated. And diagnosis can be difficult due to structural changes that make our tests difficult. For these patients, I would just recommend don't forget to use all of the tools in your box. New OCT features like the ganglion cell complex, manual adjustment of segmentation issues, your IOP, your visual field, and other risk factors for glaucoma, such as pachymetry. Does anyone have any questions?